Welcome. I'm Willem Marks. I'm an editor for custom programming here at the Wall Street Journal. Thank you for joining us as we do a deep dive on one of the most dire health crises the world is confronting today. No, it's not COVID-19, although the ongoing pandemic has exacerbated this situation. We're talking about the 270 million people who suffer from some form of malnutrition. That's double the number in 2019, according to the World Food Programme. Here to discuss medical, social, developmental, and economic consequences of malnutrition and what can be done to ease the burden for families, communities, and society as a whole, please welcome Hakeem Buzamondo, Divisional Vice President for Global Research and Development at Abbott Nutrition, based in Abbott Park, just outside of Chicago. Leah Gramlich, gastroenterologist and precision nutrition specialist at the Royal Alexandra Hospital in Edmonton, Canada. And Jason Shafran, Senior Managing Director at the Center for Healthcare Economics and Policy for FTI Consulting. He's joining us from LA. And before we begin, I'd like to remind our audience that we'll allot time to answer your questions, so please do keep them coming. You can type them into the chat box on your screen, along with your name and company affiliation preferably, and we'll pick a few to put to our panelists. We'll also have some polling questions that will appear at the bottom of the screen. They're just our way of gauging your overall familiarity with our topic. Thank you so much in advance for being here, and now let's get started. I'd like to begin with you, Hakeem. 1 in 3 people worldwide suffers from malnutrition, and yet the concept of malnutrition is not well understood. Can you break down for us what exactly malnutrition means and give us its impact on our health and why it's relevant everywhere, including in communities across the US?
Thank you, Willem, and good morning, good afternoon, everyone. Malnutrition occurs when the body does not get the nutrients it needs. But when people think of malnutrition, they usually think about undernutrition, underweight. The reality is malnutrition is more than that. It includes underweight, it includes undernutrition, but it also includes obesity and overweight, and also diet-related non-communicable diseases. The important thing about malnutrition is that it occurs in high, middle, and low-income countries around the world, with some common causes to all and others very different. And the main issue around malnutrition, it's really that it often goes recognized, as it can be invisible to the eye, and it's not regularly assessed during doctor visits. So back to your question about the impact, Willem, there's a developmental, economic, social, and medical impacts of malnutrition that is serious and lasting for individuals, families, communities, and countries.
Leah, can I ask you, in your work, in the communities where you work, what's the impact of malnutrition?
In hospitalized patients, malnutrition affects up to 50% of the population. 1 in 10 might be severely malnourished, and 1 in 3 are at risk for malnutrition or are potentially malnourished. In community, the rates change. For instance, in free living elderly, the prevalence can be anywhere from 3% to 12% in a community, and the prevalence increases as populations grow older, as people grow older. When I see malnutrition, I see it in patients who aren't getting enough to eat, who have the impact of disease, and the consequence of that malnutrition is functional disability. They can't walk as well, they don't heal wounds, they're more likely to stay longer in hospital or require readmission to hospital. It's a significant consequence both for the individual in terms of increasing their risk of complications and burden of illness, but also for health systems from an economic perspective.
Well, that brings me nicely to Jason. We often hear about the health impacts of malnutrition, but what about those economic impacts? What's the economic cost of malnutrition in all its different forms, and what does all of this mean for healthcare?
Yeah, thanks, Willem. If you think about the overall societal economic impact, there's been a number of studies that have tried to answer this. If you look at the US, the economic burden of malnutrition is about $150 billion per year. And that's a large number. Where does that come from? One, there's extra costs to treat people who have malnutrition because their diseases get more severe, et cetera. Two, the economic impact in terms of people dying sooner, and also more severe disease in terms of worse quality of life, et cetera. If we just look at kind of the economic direct costs, not quality of life, not mortality, but just the direct economic cost of treating malnutrition, that's $15.5 billion per year just in the US. If we go kind of around the world, if you think about Europe, there's similar numbers. There's been estimates that those are about 30 billion euros per year for the direct cost to treat adult malnutrition. In China, just disease-associated malnutrition, not including kind of poverty-related malnutrition, but disease-associated malnutrition, the annual cost was about $66 billion per year. So that's kind of the overall societal impact. If you think about kind of health systems and hospitals specifically, as Leo's talking about, malnutrition leads to more expensive hospital stays because you have longer hospitalizations, people have more complications, they're more likely to be readmitted. There's one study that said hospital costs for people who are malnourished were about twice as much as similar patients who are not. So just kind of overall, the economic burden is really high and kind of experienced really around the world.
Hakeem, talking of the global situation, we've seen this COVID-19 pandemic affect pretty much every aspect of our lives, our health. We've seen it also impact access to food. We've had shutdowns, trade restrictions, people being frightened of going out in public. Can you talk about what kind of impact COVID-19's had on malnutrition and whether or not there's actually been some positive changes sparked, at least in terms of awareness?
Well, indeed, COVID-19 pandemic exacerbated the nutrition challenges we've been facing for years due to increased food insecurity and also the overloaded healthcare system and limited access to healthcare that Jason did mention. And there's a preliminary assessment that is suggesting that the COVID-19 pandemic may add between 83 and 132 million people to the total number of undernourished in the world in 2020, depending on the economic growth scenario. Now, COVID-19 can cause poor food intake, reduced physical activity, increasing nutritional needs, which can exacerbate or lead to malnutrition. And one of the immediate and positive actions that was taken by ASPEN, which is the European Society for Clinical Nutrition and Metabolism, was to publish 10 practical recommendations on the nutritional management of individuals with COVID-19. And the guidance underlines the importance of identifying either people at risk or malnutrition or people who are already malnourished and intervening with proper nutrition by providing enough protein, calories, vitamins, minerals as soon as possible. So when you think of COVID, there are different forms of COVID-19. So there are these mild cases of COVID and you're only at home, or there are these more severe cases of COVID when you're sitting in an intensive care unit. So the risk of malnutrition and muscle loss increases with the severity of your disease and the fact that you have a reduced physical activity, lower appetite, and especially for the moderate to severe cases, you have increase in inflammation. And this is where your body starts breaking down for energy. So these are all very important learning that we got from the COVID-19 pandemic and how our healthcare systems and healthcare professionals adjusted and adapted to these new needs.
And Jason, from an economic perspective, there's a distinction between preventative medicine and reactive healthcare. And I just wonder, has COVID-19 shown how important preventative well-being and health is in terms of saving money down the road on healthcare costs?
Certainly, I think that's certainly the case. I think one thing that COVID really highlighted is the importance of food security and nutrition. A recent study found that because of COVID, about 27% of people were worried about their ability to buy food during the pandemic. The impact of malnutrition and food insecurity, certainly the incidence is higher among low-income individuals, among racial minorities. There also has been kind of more awareness that to get good health outcomes, the preventive side not just includes preventive medicine, but also kind of social and economic factors. If you think about stable housing, employment, transportation. There actually was a recent article this week in the Kaiser Health News where there's a senior vice president at the Temple University Health System who said that the most important social determinant of health is food security. So, I think COVID has certainly raised the awareness that these other factors are really important for preventing and improving health outcomes. And also, I think, COVID certainly has, I think, from a perspective of technology, been able to has the potential to reach more people. About 30% of all visits were televisits at the height of the COVID pandemic. And that presents a real opportunity for outreach for malnutrition screening and eventually treatment. There is a challenge of training providers to do that via telemedicine, but COVID-19 certainly has changed how medicine is practiced, and we'll have to adapt to that changing paradigm.
Leah, how does that translate into your everyday experiences in terms of the changing face of medicine, in terms of the interface between providers and patients?
Hakeem has nicely identified that in patients with COVID, they have an inordinate impact on nutrition intake symptoms. People have loss of taste and loss of smell, and their appetite goes, so they're eating less. In that range of illness between acute critical illness and those patients who simply might have community disease and live in the community, stay in the disease, they still have impact symptoms. What about the family members who've been exposed to those patients who are now required to isolate and have a harder time going out for groceries? What I'm seeing in my practice is exactly what has been described, the impact of food insecurity. So if we define food insecurity as not having enough money to buy food at the end of the week, we have looked at our own patient populations, and about 2/3 of patients who are on social security or social supports are running into issues with food security. But in fact, food insecurity issues arise in about 2/3 of the time in patients who are actually employed and have jobs. So at the end of the day, these patients might be sick in hospital, go home, not have any food at home, not have anyone who can help them provide food, and their illness can preclude really good food intake. There's another unique consideration with the patients with COVID. Prior to COVID, our average length of stay in a hospitalized medicine patient was about 10 days. The average COVID patient stays in hospital for 20 days. So not only does that cost the healthcare system more, but that patient is more subject to frailty and functional debility as a consequence of their illness. That is going to have impact once they get back to community. So we're seeing it.
Yeah, I just want to stay with you. You're the co-chair of the Canadian Malnutrition Task Force. We all know that the reduction in malnutrition has been something that organizations across the world have focused on, prioritized for quite a few decades. And yet this is not going away as a health challenge. Can you explain to us, in your context, in your communities, why is malnutrition such a difficult problem to address?
It's interesting when you say malnutrition, we think of the African child with a bloated belly and kwashiorkor. But I think Hakeem identified it. We're not very good at identifying malnutrition. So within the Canadian Malnutrition Task Force, about 10 years ago, we did the Nutrition Care in Canadian Hospitals study, where we looked at community and academic hospitals across the country. And in 1,000 Canadians, 55% were well nourished. a third were at risk for malnutrition, and 1 in 10 were severely malnourished. The interesting thing was that in the absence of system-wide approaches to target nutrition care to those at highest risk, our dietitians or nutrition healthcare professionals were seeing the well-nourished 3/4 of the time, and we're seeing the severely malnourished only a third to a quarter of the time. So in the absence of screening strategies to identify those at risk, we weren't putting our money where it needed to be. And so what we've been trying to do within the Canadian Malnutrition Task Force is to use implementation science to put what we know into action, looking at aspects of nutrition care that help us get the right healthcare professional targeting the right patient. And in addition, what we need to do is we need to make sure that we follow these patients out from their hospital stay into community. In the past, when we were working in healthcare systems, we used to think once the patient is discharged from hospital, it's the job of their primary care physician or their medical home, and there wasn't a lot of communication. But particularly in the case of malnutrition, where the social determinants of health and access to food and resources play such a big role, we can't afford to drop the ball. So we're shifting with COVID in particular, because those transitions of care between hospital and home or home and hospital are opportunities to identify those patients. We've got this mnemonic: feed, find the patient, evaluate the patient, educate the patient and their family about the fact that they do have malnutrition, and direct those patients to resources or supports that can help them. We found that physicians are really important opinion leaders for patients, and that reinforcing that message for the patient and their family member that they have malnutrition and that that malnutrition has a consequence. It's a way to help patients be able to focus on something they can control relative to their recovery. Really important.
Hakeem, that transition, just to say, from the hospital to the primary care physician to the community, so that there's kind of a team effort across the different spectrum there. That's obviously a bit of a luxury for some people in many parts of the world. You're responsible for around 600 scientists at 5 R&D centers worldwide. How different is this problem, and how different are the approaches to tackling it around the world, would you say?
So malnutrition can look very different in different contexts and amongst different groups of people. So looking at the entire world, we're tackling one problem, but a problem that can have multiple causes. And this is why malnutrition is so difficult to tackle, because it is so complex and often systemic and require collaboration across many sectors of society to address. So I'd like to build on what Leah said, the fact that we have to identify these people, these patients, and this is a reality that is the entire world. This is really the one key missing factor, which is appropriate screening for malnutrition, be it in the US or in India or in China or in Europe or in Africa. This is really something we need to get better at. So I did mention earlier that malnutrition very often goes unrecognized and untreated. So in the hospital setting, if you say you suffer from heart failure or cancer, the healthcare provider is more likely to focus on treating your condition, your primary diagnosis, and yet malnutrition can remain as an underlying problem which is not detected. So again, from that perspective, this is really the one common missing factor around the world. Obviously, once we have the diagnosis made, then the approach to that is different, because the approach that we would have in the developed countries would be different from the one that we would have in some other parts of the world.
Leah, would you agree with that? Would you say that in your context, it really is about detection? That's a failure that you're seeing across the board in Canada, as well as obviously what Hakeem's saying about that being a common challenge globally?
It is, and it in fact is something that we can change. We can move the dial on screening for malnutrition. It's something that can happen at a health system level through intake processes. It doesn't require a dedicated healthcare professional, so it's something the health system can help with, but we have to raise awareness, and that's the beginning of the journey. I think it's also really important to include the patient and their family in this journey, because although patients can't control the chemotherapy they get or the surgery or the radiation, they can be influencing how they eat, what they eat, and that's an important aspect. So finding those patients and targeting our resources and tailoring care to those patients at the highest needs so it meets their needs is going to be one of the strategies going forward to help us find success. So tailoring care to those at the highest risk and using screening strategies broadly at a system level to identify those at risk so we can harness and use the resources we have.
Jason, I want to ask you about strategy and making strategies sustainable. You've worked on developing advanced quantitative analyses, new kinds of modeling to address some of these really difficult health problems from an economic perspective. You've talked already about the importance of tackling malnutrition in a sustainable way. What does that look like from an economic perspective? How are we going to get to that point?
Yeah, I mean, I think one of the things that Hakeem mentioned was, a lot of the providers are focused on the specific disease. And, part of the reason is, providers are overstretched with guidelines, with quality measures, payers' budgets are, they're very concerned. And so it's really important that any intervention, for malnutrition or otherwise, that really has a good bang for the buck. And so there is a lot of evidence on this already. Some studies have looked at treating, optimal nutrition care in terms of both screening and treatment in the hospital setting. And they found that when you implement the optimal nutritional care, that reduced readmission rates by about 29%. The length of stay fell by about 26%, which is about 2 days. And the cost savings was about $3,800 per patient. Leah mentioned, it's important not just to do this in the hospital and then kind of throw this over the fence, but, post-acute care as well. There's another study looking at optimal nutrition care in the home health setting. They found about a $1,500 savings per person over a 90-day episode of care. And even in the outpatient, there's another study looking at that, where there's a decreased healthcare utilization by almost 12% and a savings about $500 per person. So I think, given all the different priorities that the healthcare system has, it's vital to prioritize those that have a high return on investment. And the evidence to date shows that, malnutrition screening, treatment, kind of the optimal nutrition care really actually does have a good bang for the buck.
Hakeem, I wouldn't expect you to necessarily be thinking about things like return on investment as the leader of several hundred scientists, but of course, budgets do matter. And how do you think, from your perspective, we go about dealing with malnutrition in a sustainable way? How do we get to that point?
So what is extremely important here, you mentioned ROI, but before I get there, I think we need to come up with nutrition solutions that are made accessible and affordable. You cannot talk about ROI if you're not making these things affordable and accessible to people. So what we do at Abbott is really designing our technologies and products for broader access and affordability at every step. So from every phase of our R&D process, to the material we use, to manufacturers, to the way we reach the people who need them, and across also our businesses and through collaborations with academia, with different institutions, we're creating these new technologies and finding new answers for chronic health conditions like malnutrition. So again, at Abbott, we are really assessing innovative ways to create nutrition solutions that are easy to implement, and nutrition supplements that are easy to access and can help patients across different care, so to get them the proper nutrition they need. If we're not able to do that, so we won't be able to solve the malnutrition epidemic.
So, Hakeem, do you draw a direct line then between affordability of this nutrition you're describing and then accessibility?
Well, I think they both go together, Willem. There's no accessibility without affordability, and there's no affordability without accessibility. So what we need to do is really developing these products that would become available to the wider population, and make sure we get them to the end user, to those children that are suffering most of malnutrition in countries like, in some countries in Africa, or to these people who might suffer from obesity in the US. So we really need to make that accessible and affordable for this entire population.
And Jason, just to come back to you about return on investment, no one says that healthcare systems are simple or straightforward. They're clearly not. But how do you marry accessibility and affordability when it comes to tackling malnutrition to the larger public health efforts being made to keep costs down, essentially?
Yeah, I mean, I think if you think about, say in the U.S., 31% of people who have employer-provided insurances now have high deductible health plans. So there's kind of a trend to moving more costs, to the patients. And I think, that is, sometimes a challenge, that how do you get, public health interventions or things like that have a good return on investment and make sure they are easily accessible. There have been some proposals like value-based insurance design where, low co-payments or low cost sharing for high value treatments, and for treatments and interventions where there's, more cost, smaller health improvements, you end up paying more. So that's something to think about. There's kind of another trend for value-based payment for providers where when providers provide high quality care, they get reimbursed more. And in fact, 61% of payments in the US to providers are now value-based in some form, either linked to quality or shared savings or things like that. So on the provider side, the incentives are being aligned to better implement things that have high return on investment. I think one of the key issues is making sure the providers are aware of the malnutrition screening, treatment, et cetera, so they implement it, because the incentives are being more aligned to implement these high return on investment strategies, such as optimal malnutrition care.
So just as a reminder, we're talking about all aspects of malnutrition. Those of you who may be joining us or are still with us, I'm talking to Hakeem Buzamondo, Divisional Vice President for Global Research and Development at Abbott Nutrition, Leah Gramlich, gastroenterologist and physician nutrition specialist at the Royal Alexandra Hospital in Edmonton, Canada. And that was Jason Shafran, you just heard from there, the Senior Managing Director at the Center for Healthcare Economics and Policy for FTI Consulting, who's in LA. Leah, let me come to you. This is a very broad question. I appreciate that, even in asking it. But if we look 1 or 2 decades from now, 10, 20 years down the road, what do you think malnutrition might look like? How will nutrition and the way we think about nutrition change? And what does this mean for people's health?
You know what, I've been thinking a lot about this, and think back, look ahead. 20 years ago is when the obesity epidemic hit, and all of a sudden there was a real awareness of the relationship between overweight and bad outcome. I'm really pleased that we now are saying that malnutrition is on the radar, because it absolutely affects a large proportion of our population locally and globally, and it's of significant consequence. I think in 10 or 20 years, what I would like to see is universal screening adopted in our hospitalized patients, and targeted strategies to target optimal nutrition care for all, with increasing reach into the community. We've talked a little bit about how supplements may offset this nutritional deficit that contributes to morbidity, but I think that there's also an opportunity to partner effectively across sectors with our community partners, and we've been working on that in our local communities across Canada, and there's an appetite for that. So if we can coordinate efforts to identify malnutrition and find multiple approaches to deal with this problem, whether people have illness or issues with food insecurity, I think that we can move the dial. And I would like to see lower prevalences and access to food and nutrients for all.
And that access for food and nutrients, Jason, people don't typically tie that to concepts like GDP, but what do you think changes in terms of our approach to malnutrition might mean for economic growth over the next couple of decades?
Yeah, I think, if you look kind of in the long course of history, and you see that the economic growth happening, people are getting richer. Obviously, with COVID, there was a blip. So I think on the positive side, you see certainly kind of poverty-related malnutrition is likely to decline. If you look at the statistics from the World Bank, about 2 billion people in 1990 were in extreme poverty, less than $1.90 a day. In 2015, that was 730 million, which is less than 10%. So you see a trend towards more income, potential for less malnutrition-related poverty. At the same time, you have increased aging of society. So, in the US, Europe, China especially, a higher share of the population is 65 and above. And about 80% of people who are 65 and above have at least one chronic condition. And people with more chronic conditions are more likely to use the hospital, emergency department, et cetera. People with 5 or more chronic conditions, they make up 12% of the US population, but 41% of costs. And so when you have a large elderly population with a lot of chronic conditions, the likelihood of disease-associated malnutrition will increase. So there is a risk of an increased disease-associated malnutrition in the future. And some of the interventions that Leah has mentioned and Hakeem, certainly can be useful to address that. I think as we go forward, how do we better leverage technology to ensure that those people are kind of functional, contributing members of society, that they're able to, help, live happy lives. Telehealth with COVID has certainly been one key opportunity. How do we screen for that better with telehealth? In the future, as we develop new technologies, potentially, passive sensors for identifying malnutrition, or even apps to do that. So thinking about how we can use technology to better address, especially the growing risk of disease-associated malnutrition.
Hakeem, for you, Jason, they're talking about the trend line potentially for malnutrition pointing downwards. What do you think the future looks like in terms of nutrition, how we address malnutrition from a global health perspective? And Hakeem, I hate to say it, but I think you're muted.
Am I? Can you hear me?
Yes.
Oh, sorry about that. There are many factors to consider when we look at the future of nutrition. And for instance, we shouldn't disregard the importance of climate change and the future of technology. But one thing is certain is that we cannot look at the future of nutrition without examining the future of health, as the two are interconnected. So I could mention, for instance, the importance of having a better understanding of an individual genetics, microbiome, nutrition phenotype. And this will provide us the opportunity to take into account non-communicable diseases such as diabetes, cardiovascular diseases, risk factors when addressing nutrition needs. And as consumers continue to evolve and think differently about climate change, identifying ways to provide adequate protein, energy, micronutrients, this will challenge us to think all about how we're going to get this food in the future to ensure that everyone has access to the nutrition they need.
Those are all the questions I wanted to ask you guys. We do have some really great questions from our audience, though. So let's start with this one from Vernon Rose for you, Hakeem. What are the screening tools for malnutrition, and where can they be found?
So there are multiple tools for malnutrition, and just I would take one example, and the example of one inexpensive tool that is a validated tool, and this is called the MUAC Z-score tape, and this stands for the mid-upper arm circumference tape. And again, this is a great example on how we can diagnose malnutrition in stunted or wasted children. And basically, it's you take the tape here and you measure the circumference of the arm. And it's simple, it's paper-based, it's inexpensive device, and it includes customizable age-specific indicators to assess the risk of malnutrition in children. We have similar tools, not tape, but also for adults, where we can use screening tools by asking very simple questions. So these tools, and Leah can definitely comment on that, can be found in all hospitals, and you have also free access to these tools on many websites.
Leah, I do want to ask you another question that's come in from Lena Pradan-Nabzik, asking, and I don't want to hear any Canadian bias here, but are there any communities or countries that you think have done a good job of tackling malnutrition? And what are the learnings that we should take away from those communities or countries?
Kudos to the European Union for over a decade ago identifying malnutrition as a problem that needed to be addressed. There are exemplars of excellent malnutrition care across the world. The Dutch do a really good job. They report on it annually and audit practice. Within the Canadian Malnutrition Task Force, we're trying to create a community of practice by providing resources and tools. Hakeem has mentioned some screening tools, but the important thing about the screening tools is it has to be the right tool for the right patient population, and what you want to do is ensure that you have a validated tool. So if you're looking at stunted children in Africa, maybe measuring mid-arm muscle circumference using an appropriate tape is a good idea. In seniors living in lodges, you want to use a different validated screening tool. So you want to have the right tool for the right patient population, and that's the entry point. I think that the American Dietetic Association and Aspen have done a good job of creating care pathways like we have in Canada. I think that we look to these professional organizations to help guide care and provide guidance to the clinicians. And we expect actually the clinicians to look to their executive suite in healthcare organizations to compel senior executive leaders within healthcare systems to adopt malnutrition care. It's not glamorous, but you will get a good return on investment and patients will benefit.
Hakeem, let me just ask you very briefly, is there any community or country where you've seen some research recently that you think shows they're doing a good job of tackling malnutrition?
I'll talk about the US and the work that we at Abbott have been doing with Advocate Healthcare. So we run multiple studies with them where we could help identifying malnourished patients, but also, as Jason mentioned earlier, identify how big is the economic burden on our healthcare systems, and developing, methods to assess how much this costs to our community, and how nutrition and the right screening, but also the right nutrition that you bring to these people can help our healthcare system. So the US is also doing a very good job, but there's, I would tell you, still a lot to do.
Well, there's clearly a lot more ground that we could cover on this subject, but we're going to have to end it there. We hope that those of you watching took away some ideas on how various stakeholders can address this problem of malnutrition in a sustainable and potentially mutually reinforcing way, particularly as we come out of this COVID-19 pandemic. Thank you for choosing to be with us today and for your engagement. If you want to watch this session again, it will be available in just over an hour's time. Just click on the Abbott logo in the lobby or the homepage. Thank you very much.